All right, let's talk about something really fascinating and deadly. A situation where one organ, the liver, is failing and it somehow tricks another organ, a perfectly healthy kidney, into shutting down completely. It's like a physiological betrayal, and figuring it out is, well, it's a matter of life and death. So let's set the scene. Imagine you're on the ward. You've got a 58-year-old patient with cirrhosis, a known history of liver problems. His latest labs come back, and they're bad. His creatinine is just climbing and climbing. I mean, it's a clear sign his kidneys are failing, and they're failing fast. But here's the kicker. There's no obvious reason why. No injury, no drug, nothing. And this isn't just a textbook case. This is a real urgent clinical puzzle, and the clock is ticking. Okay, so when you see advanced liver disease and this kind of sudden, out-of-nowhere kidney failure, one prime suspect immediately jumps to the front of the line for any doctor. To really tackle this thing, you gotta know what you're up against. You have to name it. And that suspect? It's called Hepatorenal Syndrome, or HRS. Now here's the really mind-bending part of this whole thing, the central paradox. This is a kidney injury, but there's nothing wrong with the kidneys themselves. I mean, if you could take them out and look at them, they'd be structurally sound, perfectly healthy organs. They're just being forced to shut down. It's a purely functional failure, and it's all being driven by the chaos that the failing liver is creating in the body. Now, HRS isn't just one thing. It can show up in a couple of different ways. You've got what's called HRS-NKI, or non-acute kidney injury. That's more of a slow, smoldering decline. But our guy, the patient we're talking about, he's facing the much more dangerous version, HRS-AKI, acute kidney injury. And let me tell you, this is a full-blown medical emergency. We're talking about kidney function just plummeting over a matter of days. It's an incredibly critical situation. So, the big question is, how does this even happen? How does a sick liver manage to bring perfectly good kidneys to their knees? It's not like the liver is directly attacking them. No, it's way more complicated than that. It's a devastating chain reaction that gets kicked off deep inside the body's plumbing, its circulatory system. Okay, so here's the play-by-play. It all starts with the cirrhosis. That causes dangerously high pressure in the liver's blood supply. The body, trying to deal with this, does something drastic. It widens the blood vessels in the gut, what we call the splanchnic circulation. The problem is, they widen so much that a huge amount of blood just pools there. And that means the rest of the body, important places like the heart and the brain, suddenly aren't getting enough blood. The body totally panics. It thinks it's bleeding out or is severely dehydrated, so it hits the big red button and activates its most powerful emergency systems, like the RAS system, to jack up the blood pressure. But there's a tragic side effect. In its effort to save the core, it clamps down hard on the blood vessels going to the kidneys, basically starving them of blood and oxygen. And just like that, the kidneys can't filter anymore. Their function completely collapses. This whole system is balanced on a knife's edge, and it doesn't take much to tip it over. In fact, some really common things can trigger this whole cascade. A GI bleed, a bad infection like SBP, or even something like draining too much ascites fluid from the belly without giving back albumin. Any one of those things can be the trigger that starts the whole thing. It's really just a row of dominoes waiting for that first little push. So what does this actually look like when you're standing at the bedside? Well, it looks exactly like our patient. Their urine output just tanks. It goes from very little, which we call oliguria, to maybe nothing at all, which is anuria. And remember all that blood pooling in the gut? Well, that means their overall blood pressure is often dangerously low. All the signs are screaming kidney failure, but the real root of the problem, that's much more complex, and it's hidden. And this leads us right to the trickiest part. How do you actually diagnose this? Since we know the kidneys themselves aren't the primary problem, doing something like a biopsy isn't going to help. It won't show us anything. Instead, you have to become a detective. It takes a really careful, methodical investigation to rule out every other possible cause. And this brings us to what is maybe the single most important rule when it comes to HRS. It is a diagnosis of exclusion. Let me say that again. A diagnosis of exclusion. That means you can only call it hepatorenal syndrome after you have proven, without a shadow of a doubt, that it can't possibly be anything else. So, what are we talking about here? What exactly needs to get crossed off the list before we can make this diagnosis? What's on that clinical checklist? Well, the investigation kicks off with 4 key steps. First things first, you have to rule out things like shock or even just simple dehydration. Next, you go through their medication list with a fine-tooth comb and stop anything that might be even slightly toxic to the kidneys. Third, you get an ultrasound of the abdomen to make sure there's no physical blockage, no plumbing problem in the urinary tract. And last, you analyze the urine itself, looking for any clues that might point to a different, intrinsic kidney disease. Okay, so once that initial workup is done, you move on to the official diagnostic criteria. The patient has to have cirrhosis with ascites, that's the fluid in the belly, plus a confirmed acute kidney injury. And then comes the big test. You stop all their diuretics and you give them IV albumin for 2 straight days. What you're doing here is seeing if the kidneys will wake up if you give them more fluid volume. If they still don't improve, and you've already confirmed there's no shock, no nephrotoxic drugs, and no structural damage, only then, after all of that, can you finally make the call. So let's go back to our 58-year-old patient. After going through this whole process, guess what? He meets every single one of those criteria. His kidneys didn't respond one bit to that albumin challenge. Every other possible reason for his kidney failure has been systematically checked and confidently ruled out. The mystery is solved. The diagnosis is, without a doubt, hepatorenal syndrome. So there we have it. We figured it out. The liver is the culprit, causing the kidneys to shut down. But this leaves us with this incredible paradox, and honestly, one of the biggest challenges in medicine. Think about it. How do you fix a kidney that isn't even broken in the first place?